How is that?
Got it.
Got it? Okay. I introduced myself before, but again, I'm a doctor of physical therapy. I work out of Ballantyne Outpatient Rehab. I was in Matthews for many, many years. Um, we are starting to expand a lot of pelvic floor therapy for women and men throughout Novant in general, but especially in the Charlotte area. The learning objectives, I'll just run through them quick, is just to review some pelvic anatomy and pelvic floor muscle relevant to PT, summarize common prostate cancer treatments and typical side effects, educate on PT evaluation and evidence-based treatments such as biofeedback, pelvic floor muscle training, timed voiding, habits, diets, etc., and provide references. Um, I mean, who know physical therapy for prostate cancer, big question, but who knew physical therapists did this? We hear this statement a lot from people. A lot of them like to ask me how I got into this. It's a long story, but pelvic floor physical therapy is a specialty practice section of physical therapy with focus on pelvic floor muscles. So currently it's classified within the section of women's health. But it's a poor name because our scope of focus is not just on women, it's men, children, oncology, neurological issues, and just generalized pain. So I mean, we get everything from, incontinence with women to post-prostatectomy issues to tailbone pain. I mean, we get everything. So this is just a list of the APTA, our American Board of Physical Therapy, the 8 areas of specialty. And I just want to emphasize that women's health includes all of what I just spoke about with the focus on pelvic floor muscles. Just to go through anatomy a little bit, a lot of you already are very familiar with this, but the male pelvis contains some key organs such as the bladder, the prostate gland, which it gets taken out or partially sometimes, and the rectum, as well as the penis and the testicles. There's the tailbone here, and then in the front is the pubic bone, and the muscles run from the front to the back and act as almost like a sling or a hammock at the bottom of the pelvis. The male pelvic muscles, also known as the Kegel muscles, not to be confused with the glutes. They're very, very different. So as a pelvic floor therapist, our primary focus is on these muscles of the pelvis, known as the pelvic floor. Many know the muscles as the Kegel muscle, but these are the muscles you squeeze to stop your flow of urine. And if you look at it, the attachments go from the tailbone in the back and to the sides of the pelvis and then to the pubic bone in the front. There are some muscles also at the base of the penis that we also talk about a little bit during our pelvic floor evaluations. The function is for urinary and bowel continence, control, sexual function, and to support the hips, lower back, pelvis, and all the pelvic organs. And they really are just like any other muscles, they're just in a more intimate place. So we treat them as other muscles. Um, but what can go wrong if there's like any other muscles? We can get tightness and stiffness in them and trigger point pain, just like any other muscle. Weakness in coordination, so they're not doing what you want them to do. Sometimes you think you're squeezing and you're pushing, and vice versa. Um, but the good news is that since they are just muscles, they can be improved with the help of physical therapy. Okay, prostate cancer treatments. So now that we know that we have muscles in the pelvis, how are these muscles used and what can therapy do in regards to prostate cancer? There are several different treatments that are offered for patients based on this stage of prostate cancer, and treatment plans can include one or several different treatments, including radiation, chemotherapy, hormonal therapy, surgery, or prostatectomy, simple versus radical, open versus minimally invasive, and then there's a watch and wait. The treatment options of radiation and surgery are the ones that tend to have the greatest effect on the pelvic floor. So we'll focus on the radiation and surgery, um, but we can make impact and provide suggestions and education for any patient with prostate cancer, regardless of the oncology treatment. And most of you know the differences between the simple versus radical, but I'm just going to run through everything real quick. In layman's terms, simple prostatectomy only removes the inner portion and is usually for an enlarged prostate. The radical prostatectomy completely removes the whole prostate gland and the surrounding tissue, including sometimes nearby lymph nodes, usually for localized prostate cancer. And I am lymphedema certified as well, so I do deal with sometimes with people with lymphedema. There's a few of us in Novant Health. Both can be performed either open with a large incision or minimally invasive with a small incision using either laparoscopy, a lap or robotic assisted. And just understand, I want to emphasize that we treat post-surgical patients, but this is not our scope of practice, obviously. We're specialists in muscle, bone, and joint. Overall function of a patient is what we really deal with. Our goals are usually very functionally based. We treat the problems associated with surgery and radiation, which are the quantity of life. So your doctors, your physicians are working on trying to keep your life longer and heal your cancer. We are quality of life. So anything that causes your life to be not the way you want it to be is what we help you with. With radiation and surgery treatments, there are several listed side effects of the ways which pelvic floor and muscle can be affected. Many of these symptoms that are resultant from the radiation, but can also be symptoms of pelvic floor muscle issues in general. So whether the issues with the muscles are just a need to re-educate our bodies or our pelvic floor muscles specifically, there may be options to help reduce most of these symptoms. So it's urinary frequency, which is peeing too often, obstruction or stricture and retention, where you can't pee very much. Nocturia is getting up too many times at night. Incontinence is, of course, self-explanatory. And then with the bowel, sometimes we get people that have had radiation in specific areas that affect the bowel with diarrhea, urgency, and frequency also. Hemorrhoids due to too many frequent bowel movements or due to constipation issues. Anal irritation, incontinence, and pain. And then we also deal with erectile dysfunction and lymphedema, a little bit lesser effect, but we work with physicians to really work with that. So why is it important? Basically, it's an all-out quality of life. So the symptoms and side effects of the other slide, the last slide, can take an impact on a patient's quality of life. Urinary dysfunction creates overall physical, emotional, psychosocial, and economic stress. And a lot of people don't think about the economic stress, but it costs a lot to be buying pads and medications and all the different things that you need to use to try to keep yourself clean and dry. Urinary dysfunction, meaning leakage, retention, or frequent use of the bathroom, can cause physical, emotional, and psychosocial problems because whenever you go out, you may have to use the bathroom a bunch of times. You may not be able to sit through dinner, go to the movies, watch a movie with family. Sometimes it causes a lot of problems that are outside of the physical. As many of you know this, I mean, you think about how it's changed your life after treatments. Urinary dysfunction is usually about 3 to 5%, according to most research and according to how many patients I actually see that are men post-prostatectomy. But usually the recovery period of about 6 months is a spontaneous recovery. A lot of men regain function of their bladder and urinary issues get better within that 6 month time. Usually I see the 3 to 5% that don't get better in that time. And range of sexual dysfunction after surgery with prostatectomy patients is 25 to 100% depending on the study that you look at. So it's very significant quality of life problem. Sexual dysfunction or ED, including ED. Why don't men seek help? There's a lot of reasons why men don't. And first one would be perceived vulnerability and fear. Fear of diagnosis or fear of what the treatment might be. A lot of people think about not only just what they have to do medically, but they've been through so much, and then the doctor wants to send them to pelvic PT and they don't even know what to expect. So sometimes they show up and then they come back, and sometimes they don't. But if they do show up many times after the evaluation, we spend a good 45 minutes per patient. And it helps me be able to establish a rapport and an education of patients, and they tend to always want to come back. So the traditional social roles, masculine norms emphasize self-reliance, and seeking help may feel like a sign of weakness. Systemic barriers, a lot of times it's maybe your job has time constraints, you can't get here, or difficulty accessing care through maybe lack of insurance or something like that, or there aren't pelvic health therapists in your area where you live. But the barriers of certain things like time constraints and work, I can usually work around people's schedules pretty well. And then there's the mental health stigma, which actually is self-explanatory, but it has gotten much better. I have to say the one positive of COVID is that people seeking help for mental health issues has increased drastically, and I'm happy about that, to see people open to getting help and people talking about it. Specific versus general health concerns. A lot of men will seek help in general for general health checkups and things like that, but not usually for very specific things unless it's a traumatic thing. But a lot of times they'll live with their problems if it's, low level and they think they can. And support systems. In this case, they have to turn a lot of times to their partners, and their partners tend a lot of times maybe female, um, and rather than their male peers. So having um, a support group like this is phenomenal. I've never been in attendance of this, but I plan to come back because I think it's great. It's a safe place for men to be able to talk to other men about these issues. So a lot of times, unless it's a sports injury or something, they don't tend to talk like women do to each other. And then understanding sexual dysfunction. Sexual dysfunction, including erectile dysfunction, affects millions of men worldwide. That's why there's all kinds of companies offering all kinds of pills and medications and treatments for this now, right on the commercials, during football games. But common causes include psychosocial factors, chronic illnesses, lifestyle choices. Treatment range from medication and therapy to lifestyle adjustments, emphasizing the importance of open communication with your healthcare provider provides effective management. So the prevalence it's global, of course. The causes of dysfunction aren't just psychological or chronic illnesses and diabetes, which do tend to cause this problem, but also surgeries, including prostatectomy, and treatment and communication. Effective management involves a lot of different aspects of healthcare. And I think we need to start opening our minds to, is there physical therapy that might be able to help physicians who are on a very big time constraint? We have much more time to spend with patients. So sometimes utilizing our services is really helpful in treatments of this. We're going to go back to, again, sexual dysfunction, erectile dysfunction. Medications are effective on average for 60 to 80% of healthy men. If you add diabetes, I think I spelled mellitus wrong there, sorry. 40 to 60% of men with diabetes tend to respond to these medications, but then you're looking at the rest of the men don't. 25 to 40% after prostatectomy. But other things can lend itself to having ED or having sexual dysfunction in general is low testosterone, blood pressure meds, SSRIs, which are depression meds, and that they also may impair the response. And then you add like, all right, 25 to 40% of people with prostatectomy, but then a lot of times you're on hormone suppressants, so that adds to it. And then some people may be on blood pressure meds, which is going to add to it. And then because of all of the treatments you've been through and all of the problems and the stress level when it comes to jobs and everything else, you may be on depression meds or anxiety meds, and they can also impair the response. So all of those things can be contributing. What I want to talk about today with sexual dysfunction and erectile dysfunction is that treatment really begins with lifestyle choices. Um, Losing weight reduces issues. Sometimes if you lose a decent amount of weight, you can reduce your chances of diabetes. If you were pre-diabetic before or had type 2 diabetes due to the weight gain, you might be able to go off diabetes medicine. You may have better blood flow because diabetics have lesser blood flow to the extremities as well as to the genital area. And hypertension, you can reduce blood pressure by losing weight and exercising. So you may be able to get off of hypertension medications. So, and then building muscle, that improves oxygenation throughout the body, including the pelvic floor muscle. So it's going to help with that, with strengthening of the pelvic floor muscles. And compression of the last thing I look at is learning to breathe properly because and avoiding constipation because Valsalva or breath holding, bearing down on a regular basis or wearing really tight clothing that doesn't allow you to breathe normally, that decreases blood flow to the perineum and you need blood flow to in order to have an erection or even maintain an erection. So some of these things are within your control and I feel like I work a lot with breast cancer patients. I work with prostate cancer patients. I work with a lot of people just sent to me for erectile dysfunction. And we talk about all of these things. They have to be willing to make changes in their own lifestyle to help the situation. So improving pelvic floor muscle activation, relaxing those muscles. Some people come in, they're very, very high anxiety. They've been through a lot. They're very tight and their shoulders are at their ears, and I know those people are going to have hypertonic or non-relaxing pelvic floor muscles as well, because it is a posture muscle. And that is going to decrease the amount of blood flow to the perineum and the penis. So those are the things that we can really help you with. Okay, urinary problems. Stress urinary incontinence due to increased abdominal pressure and weakness in the pelvic floor. Usually that's a cough or a sneeze. If you exercise, lifting something heavy, jumping, that kind of thing. Urge urinary incontinence is due to either an overactive bladder or poor urinary habits where you would just in case peeing all the time. Before you leave or before you reduce water intake and sometimes that'll make the bladder really irritated and make you have to go to the bathroom more often. And then urinary frequency is part of sometimes you have incontinence with it, sometimes you don't. But water intake, habitual, just in case peeing, poor diet, over rely. Oh, the other thing I want to mention is there's a lot of times that men have incontinence after a prostatectomy. Those are the ones that usually have incoordination and weakness of the pelvic floor because the prostate actually acts as sort of a backup sphincter for the urethra. So when you kind of can get lazy. You have a long urethra, so you don't leak as much as women do. So usually your pelvic floor muscles aren't as necessary for urinary control. So when they take the prostate out, a lot of times now your backup is gone. You have to use your pelvic floor muscles, and we find they're weak and coordinated, and we have to work on those to be the backup now. Recovery and the role of physical therapy. Now, pelvic floor muscle strengthening, most of the time we're dealing with weakness. A pelvic floor muscle assessment helps us to determine the correct treatment methods for each person. So, weakness may cause urinary leakage, where an inability to relax those muscles may result in diminished blood flow to the penis and perineum area, which could contribute to ED. Um, then we also work with all the muscles of the core, which include abdominals and glutes, and your back muscles. Breath training is important to avoid breath holding and allowing the all-important blood flow to that perineum and penis. Bladder training, retraining. So we're reteaching the bladder and the brain and the pelvic floor muscles to all work together. We want to establish normal urinary frequency and control, and it may mean we increase fluids or we decrease fluids or the type of fluids you're drinking, or it may mean time voids where I put you on a schedule for voiding before leakage actually happens. And then we also will deal with biomechanics and integration into function. So how do we do something is just important as what we're doing. Once you learn how to exhale and contract the pelvic floor muscles and relax properly, we need to integrate that into different positions, such as maybe laying on your side, on your hands and knees, sitting, standing. We may have you do movements like rolling, sit to stand, holding that pelvic floor and exhaling at the same time, and then eventually integrate it into any other exercise. You may be doing exercises I either give you or exercise you're already doing, or maybe you want to go into the gym, that type of thing, so we can integrate it. And then there's manual treatments as needed. So there may be scar tissue in your belly, there may be tight ligamental structures around the base of the penis at the pelvic floor. And a lot of times we can do some manual treatments to help with that. Typical rehab, almost going to tie it up. Typical rehab treatment time, patients are usually seen for about 3 to 6 months, give or take, one time a week. I had one gentleman only came 3 times because he had a prostatectomy 10 years ago and just started leaking. So it wasn't related to the prostatectomy, just other issues that we could deal with. But in general, it's 3 to 6 months, one time a week usually. Um, the evaluation, we start with looking at habits, how your life is impacted. We make it very individualized because some people, if something isn't a problem for you, if getting up 3 times a night isn't an issue for you, it's not a problem for me. So I have to set my goals based on what you feel is important to you. And we do a lumbar, a low back, and pelvic evaluation, general orthopedic. We look at strength of the muscles, including the abdominals, the hips, and the pelvic floor muscles. And if it's okay and the person feels comfortable, I do an internal rectal exam to check pelvic floor muscles, to check for pain. Um, and then education using a model at the evaluation. I have a pelvic model that I use, and I issue diaries for habits, food, fluid, urination, bowel movements, leakage for about 3 days so I can take what they bring back and work with them on what matters to them and what their problems are. So I'm just going to show you just a general start with pelvic floor muscle Kegel 3 times 10 per day. So it would be 30 per day. We start them in the supine position because it's the easiest. Learning to exhale with the work. So you exhale with the Kegel, inhale with the relax. You do one set of 10 for 1 second, then one set for 5 seconds, one set for 10 to 15 second hold. I incorporate breathing and abdominal contraction with that, especially the transverse abdominis, because that works with the pelvic floor. Then we may move in other, not, this isn't all in one visit, this is going on through time, but we might move you to side lie positions, prone, quadruped, sitting and standing, progress either repetitions or hold times or both. We may do Kegels with change of position, Kegel with upright positions and walking, Kegel with exercise and gym work. And we may incorporate biofeedback, which uses external or internal sensor to read the muscles. And we can give you a visual and auditory feedback with that. It shows exact work force you're putting out. It shows relaxation, so we can get objective data to put in your chart. And docs love the objective data, so does insurance actually. And I just put a list of a few of our in the Charlotte region of who has some oncology and pelvic floor therapists in here. But I'd be glad I have some references or I got some of this information, and that's it. Thank you. And if you have any questions or comments, I'd be glad to take them.
Just one from me. Uh, you might want to sit with your urologist. Watchful waiting that you called it, watch and wait.
Uh-huh.
We dumped that term a while ago.
Oh, I'm
Uh,
sorry.
that's all right.
Okay.
Just we're educating you. We're educating you. We
Okay.
call it active surveillance.
Okay, I like that better.
Active surveillance,
Yep.
because as a psychiatrist and a health educator, watchful waiting was let's watch and wait till you die.
Yes.
Okay,
They did
versus
that with breast cancer too,
that's
where they had this
exactly
exact,
right.
I had breast cancer twice, so I
Oh
get
well,
that.
I'm glad you're a survivor.
Yes,
But so we would encourage you to move to active surveillance,
I will.
which basically says, in a nutshell, a PSA every every 3 months, and I think for urologists they would include a digital rectal.
Okay.
But as you know, the AUA is not using a digital rectal. But Victor will tell you that the digital rectal saved his life. So
Well,
that my one comment.
I'm gonna just counter that, not counter it, but I'm gonna piggyback on what you're saying. As far as breast cancer is concerned, my second cancer was found with my own digital palpation 2 months after a 3D mammogram. So you can't always depend on, you really, I think it's really, and just like I do digital exams for muscle because I can't tell what somebody's doing unless I feel it. So I am 100% behind that.
Excellent talk, Barbara.
Thank you.
Learned a lot that I think, gosh, will be valuable to GU patients. Would you be willing to share your slides with me? So I didn't
Yes.
been able to take notes. Thank you. If you just drop them in the chat, would that be
Okay.
okay? Okay.
Let me see.
Just
I don't know how to do that. Can I email it to you?
Yes, I'll drop my email address in the chat instead. That's fine.
Okay, okay.
Barbara, a couple questions. Number one, psychosocial impact of prostate cancer
Mhm.
and dealing with, say, African American men. Is there payment already approved for the physical therapy piece that you're talking about?
Well, we go through, I know that Novant Health in general has a lot of assistance. And
Okay.
it depends more on income and need. So you have to fill out an application. And Novant, I've had quite a few people that get free help from physical therapy, unlimited a lot of the time, for whatever is needed. So there is applications through Novant Health for that.
And the second question is, if we have people electing to have the surgery, is there a way to have pre-surgery exercise,
Yes.
okay.
Yes, there is.
Because it seems like if you start strengthening the muscles before the surgery,
Yep.
your recuperation time is better.
We call that prehab, and actually insurance covers that. Like even if you have insurance, it covers it.
Okay, that's
So,
great.
it's a great, we do that with knees, we do it with hips, and with any cancer patients, my lymphedema patients, my breast cancer patients, my prostate cancer. I don't get as many prehabs for prostate cancer, but breast cancer, they come in and I do all my measurements so I know where we want to get back to. It's great to figure out goals after the fact of what is your prior level of function. So even with prostate cancer, even though there's a small percentage of men who have incontinence after the fact, knowing where they're at beforehand, checking that muscle strength, checking their whole low back and muscles of their core, and it's really helpful to have that prior.
Yeah, I think one of the problems there in the research is that physicians are not inviting people to be proactive as to
Mhm.
what happens after surgery. And
Exactly.
when it comes to incontinence, you have men who just won't talk about it.
Hmm.
And if we can get what you're doing more in line with what urologists are doing,
Hmm.
I could see the numbers changing tremendously.
Yep, you're 100% right, because I get women, urogynecologists send them all the time. Gynecologists send them all the time. I get women, that I mean, it's just they've been suffering for 20 years and they haven't said anything, and finally they do. And it's become pelvic health in general in the physical therapy world. I was the only one in Novant 22 years ago, and now we must have probably 50. So it is growing. It's just very hard to recruit pelvic physical therapists and pelvic therapists, it sounds terrible, that are willing to see men because it's a separate group. It's a little bit of a different anatomy, a little bit of a different how you interact, and we're trying to get more and more pelvic health therapists that will just not shy away from that. I think it's super important.
Great presentation.
Thank you.
Any additional questions for Barbara? Thank you. That really was outstanding.
Thank you. I can't say I wasn't nervous after all the intros of all these gentlemen.
I have a question. Today this was really informative for me because I think a lot of this information is not getting out to the general men. Um, because the Kegel part was very interesting because I always thought that was a female thing. I didn't know better, but just the information that could help a lot of general men because I know a lot of men have the leakage. Like my father-in-law says, the valve is leaking now, and we think it's just a part of life. And knowing this is something that could help just improve your day-to-day health as you're getting older.
Absolutely. Absolutely. I mean, the men don't normally leak because of the prostate being present and the long urethra. But again, it makes their pelvic floor muscles tend to be weaker and more incoordinated than women because they don't depend on it as much. But absolutely, regardless of the reasoning for incontinence, a lot of times just lifestyle change, habits they have, strengthening of that pelvic floor, incorporating it in with proper breathing, and incorporating it with a good exercise program really makes a huge difference. So,
Very interesting. That's very, very interesting.
Fantastic.